Case control study designs are one of the really major and important and potentially powerful study design methods. In this video, we will address the design features of a case control study. We'll focus on how to select cases and controls, and we'll briefly revisit the calculation of the odds ratio, which you've probably already met. Case control studies are always analytical and never descriptive. So if you're doing a case control study, it's definitely an analytical study. The participants are recruited on the basis of do they or don't they have the disease or the outcome of interest. You then look backwards in time to determine if these participants were previously exposed or not. So it's a retrospective inquiry regarding the exposure. Example, we have 20 people with cancer of the larynx and 80 controls who do not have cancer of the larynx. Then we ask each of them if they were smokers in the past. Here we have a flow diagram illustrating the process of a case control study. There are two things that I'd like you to take special note of. The first is the origin of the numbers in the 2x2 table, which have labeled A, B, C, and D. See where they come from and make sure you understand why they come from those places. Secondly, notice that the direction of inquiry goes from right to left, but the direction of time goes from left to right, so they're in opposite directions. Let's turn now to the selection of cases, because that's where your case control study starts. You start with a group of cases, then you acquire some controls, and then you do your data collection and so on. So the case definition for the case must be determined before you can select the cases. You don't want some sort of ad hoc unscientific process. The definition must be clear, objective, and unambiguous. And you might want to base your selection or identification of cases on things like diagnostic procedures, such as X-ray results or laboratory test results, or it might just be clinically determined cases or records such as death certificates, ICD, discharge codes and notifications, and so on. A further important consideration when selecting your cases is that you should have very clear inclusion and exclusion criteria established before you start to recruit your cases. For example, you may want to exclude children from your study or those who are unable to give consent. You might want to exclude pregnant women or people who are unable to give a reliable count of their exposure history. For example, they might be comatose or they might be suffering from Alzheimer's syndrome and so on. Cases for your study can be obtained by looking at various sources such as hospital ward admission registers. Actually, the discharge registers are usually more informative. Emergency units, clinic registers, notification systems, cancer registries, recruitment of cases using social media, and so on. In contrast to the selection of cases, selection of controls is fraught with problems. The first problem is that there is a tendency, if one is not very careful, that you might select inappropriate controls that are not representative of the population from which your cases have arisen. You don't want that to happen because then you're not comparing to an appropriate control. So when selecting controls, consider things like the comparability principle. For example, similar socioeconomic status for the group that gave rise to the controls as for the cases. Select from within the population that the cases came from, and select people as controls who, if there had been cases, would have been eligible for inclusion as cases, so that you avoid selection biases. You must select your controls independent of their exposure. One final little note, in general, you should select up to 4 or a maximum of 5 controls per case. If you select more than 5 controls per case, your study becomes less efficient because there's very little advantage added by adding more and more controls, and yet the costs and the duration of the study will now increase. So we usually choose about 4 controls per case, or maybe 5 controls per case. For the selection of the controls, a random sample of the source population for the cases would be best, but this is rarely feasible. So we have to use other sources, but think very carefully before you do this in order to avoid the probability of selection biases. You don't want to have a biased result. Sometimes people turn to hospital emergency room controls for cases that are sick people, or people admitted with other unrelated conditions, or you might look at residential area and look at neighbors of the cases, or relatives, friends and spouses, but be very careful to avoid selection bias. Having selected our cases and our controls, we now want to interview the people that we've selected and ask them if they were exposed to the exposure of interest. And we have to be very careful to have a pre-agreed definition about the exposure, a very exact and precise definition. Don't just say to someone, "Did you ever smoke?" Maybe they did, but it was like 1 cigarette a week. So you might, for example, say, "Have you smoked more than 5 cigarettes a day on average over the last 5 years? Or did you have a tonsillectomy as a child? Or do you have a family history of asthma?" And there you need to be very clear about what you mean by a family history. You don't mean relatives by marriage and that sort of thing. So you need to be very explicit in your definition of exposure before you collect the information. Here are just some examples or suggestions about where you might find out about the disease or the exposure. You might look in patient records, lab reports, you might do interviews, medical exams, surveillance systems, death certificates, and so on. You could also go to cancer registry and looking at patient notes. With case control studies, the only direct measure of effect measure that you can calculate is the odds ratio. You can't do risk ratios or relative proportions and things like that, because you determine the number of controls per case, and this will obviously affect those proportions and those ratios. So we only do the odds ratios when we're working with data from case control studies. We compare the odds of exposure amongst the cases to the odds of exposure amongst the controls. You could, if you prefer, look at it a bit differently and look at the odds of disease amongst the exposed over the odds of disease in the not exposed. Both methods give you exactly the same correct answer. So the odds of exposure amongst the diseased would be A over C. The odds of exposure amongst those who are not diseased, in other words, the controls, would be B over D. So the odds ratio is simply A over C over B over D. And that, if you cross multiply and divide, it comes to AD over BC. So A times D over B times C. And that's the way to calculate your odds ratio. In this example, we find that there are 100 people who were exposed, E plus, and diseased, D plus. 89 who were exposed but not diseased. 811 who were not exposed but got the disease. And 2340 who were neither exposed nor diseased. The odds ratio is simply AD over BC, as we've seen. So that comes to, if we work it all out, 3.2. Now, what does this odds ratio of 3.2 mean? Well, we interpret it as follows. The odds of disease amongst the exposed is 3.2 times higher than the odds of disease amongst the non-exposed. You could also say the odds of disease is amongst the odds of exposure amongst the disease is 3.2 times higher than the odds of exposure amongst the non-disease. Both these interpretations are equivalent and are acceptable. There are two important variations of the standard case control study. I'm not going to talk to them in detail here, but I refer you to fact sheet Epi 04, where they are described in more detail. So I ask you please to read the fact sheet very carefully so that you understand the difference between these two variations and the standard case control study. In summary, case control studies are one of the major analytical study designs. You start with the effect and look back in time for the exposure, and the odds ratio is the appropriate measure of association or effect.